investigation. That is a circuit commonly asked in the examination very well. And in the afternoon Viva session, they will give you the circuit and they will ask you questions. I am actually thought of to prepare question and answer slides, and it is the time is not so short. Hello, echo is going on. All can mute your audios. All should mute your audios. Hello. All should mute your audios. So it is a valveless breathing system used in anesthesia in children up to less than 25 kg. Not you cannot use it for 30 kg. Actually, the book says in Alshek is 35 to 30 kg. But some of the examiners are fond of you have to use this circuit less than 20 kg. Then only it will become very efficient. And some examiners can extend up to 25 kg, and most of the examiners they will not accept up to 30 kg. And it is a suitable instrument that is for both spontaneous and controlled ventilation. Am I audible all? Am I audible? Rifan, am I audible?
Yes, sir. Yes, sir. Clear, sir.
Yes, sir.
Okay, okay.
Yes, sir.
Okay, all can mute their audios. And what are the components of the circuit? Components. The components having this or this reservoir bag. The first one is the T-piece and the connector, and this is an expiratory limb and the oxygen source tube and the connector to the Boyle's apparatus or this anesthesia machine. And these are all the circuits. And we have to talk about this. This T-piece is concerned. Rifan, can you show the T-piece? And regarding the T-piece, that has 3 limbs, and one for the patient and another for the reservoir tubing, and the third one for the fresh gas flow. And that is one for the patient and one for the fresh gas flow, and one for the patient. This is for the patient, and this is for the reservoir limb. This limb, it is get inside, and this one for the fresh gas flow. This T, that is right hand to the T, that is for the fresh gas flow. And the T-shaped tubing has 3 openings, I have already told. And this fresh gas flow is delivered to the one port, this one. And the second port leads to the patient's mask or the tracheal tube. And the connection should be as short as possible. This connection towards the patient end, this T to the patient end. That is the most important thing. And this is the area we can call this as an apparatus dead space. The examiners will ask you very frequently, what do you mean by apparatus dead space? The apparatus volume that can be get inside to the patient during the next act of inspiration without change in air composition. You have to answer like this. What do you mean by apparatus dead space? And the apparatus dead space is from this area where the fresh gas flow is there, here to the patient connector. And this is the area which cannot be flushed out by our fresh gas flow, and this will be there during the at the end of expiration. At the end of expiration, the area inside the gas will not be altered, and this area will be sucked in during the next act of inspiration. Can you hear it? I think all can understand what I am saying. And this third port leads to reservoir tubing. Reservoir tubing, this one. This reservoir tubing, and then at the end of the reservoir bag, there is an end of the reservoir limb, there is a bag. There is a double-ended bag. Both ends are open. How to say this? And both ends are open. And making this circuit with another name, Mapleson F. And I will discuss you about in a detail regarding this basics of breathing system, which is very tough to understand initially. I will simplify you in the next classes. What are the basic qualities of the breathing circuit? What are the original idealities? And what do you mean by rebreathing? What do you mean by resistance? And what do you mean by apparatus dead space? What do you mean by alveolar dead space, apparatus dead space, physiological dead space? All those things they will ask you in the examination. And what do you mean by rebreathing? Rebreathing is the most important thing. It is important short notes also for you. And all those things can be, and air dilution and rebreathing, all those things. These are all the common terminologies used in the breathing systems. And also you have to understand with a very good physics background. Without physics background, we can't able to understand these terminologies, even though it can be, seems to be understandable, but you cannot able to understand it properly without understanding the physics behind the circuits is concerned. And very recent modification here at this end of this, what to say, this double-ended blinded bag, end of this, recently they are adding an APL valve here. I think all can aware about it. And the APL should valve is included before the closed end of this. Capacity of this bag is 500 ml. 500 ml, and a pressure relief safety mechanism in the APL valve, that is will be there with the pressure loaded spring is there inside this valve, and the pressure safety mechanism in the APL valve is actuated at the pressure of 30 centimeter of water. That is designed in the foreign countries. We are not much aware about this scavenging is concerned, and this designs allows the designs for effective scavenging regarding once the APL valve is attached to this other end of this bag is concerned. And regarding this mechanism of this, it is suitable for, I already told that it is suitable for both spontaneous and controlled ventilation. Okay. And these are all the compounds we already told earlier. By this reform has taken this in a very good way to adapt all those things. The fresh gas flow have already discussed the second port with the patient, and this port I have already told earlier. The second port that is towards the patient or the tracheal tube inside, that should be as short as possible to reduce the, not the anatomical, it is not the anatomical dead space, it's the anatomical dead space is the space in the patient from nose to the terminal bronchiole where there is no gaseous exchange will take place. Okay. And that area is called anatomical dead space, that is roughly about 2 to 3 ml per kg. But in standard adult, we are calculating this as a 150 ml, provided we having patient having the tidal volume of 500 ml. Okay. And here the examiner asks you, what is the dead space volume in a patient, means you should not say 150 ml, they will be, the examiner will be irritated. You can answer smartly as 2 to 3 ml per kg. 2 ml per kg, that is enough. Okay. Next slide. I have already told about this third port also. This third port also leads to reservoir bag, and Jackson and Rees added a double-ended blind bag, which I have already told earlier in the previous, without showing the slide. And making the circuit is from E to F if you add a bag towards the expiratory limb of the patient. And the modification I have already told, the APL valve. at the end of the reservoir bag. And next one is some of the physics is concerned. What should be the diameter of the reservoir limb? What should be the diameter of the reservoir limb? The diameter of the reservoir limb should be sufficient to present the lowest possible resistance. I mean, that is about 0.75 centimeters of water for the neonates is concerned, and it should not be more than 2 centimeters of water for the adults, for the adult bigger babies are concerned. For in adults, it cannot be more than 2 centimeters of water, whatever may be there, circuit it may be. And what should be the volume of the reservoir limb? What should be this volume? This one. This one is the reservoir limb. What I am saying is the reservoir limb. What should be the volume? The reservoir limb should be not less than the patient's tidal volume. That is the most important thing. The reservoir limb should be not less than the patient tidal volume. But now we have discussed about it. What happens if the reservoir limb is less than the tidal volume and if the reservoir limb is more than the tidal volume? The examiner will ask you. Definitely, this question will be asked almost all to the candidates who are given to this circuit in hand during the examination. So, to grade the reservoir volume, to length, and if this too lengthy, this reservoir volume is too lengthy, and the diameter of the tube will be very less, and it will reduce the diameter of the tube and will increase the resistance. If it is 2, number 1 point. Number 2 point, more the lengthy of the tube, that should be more than the tidal volume of the patient. Suppose if you are taking this 10 kg baby, having this tidal volume of 7 ml, 10 ml, 7 to 10 ml per kg is the tidal volume. And 10 kg baby, we take it as a higher side of 10 ml per kg, that is about 100 ml of tidal volume, and this tube contains more than the tidal volume. The patient take a breath during inspiration, and whatever the gases, expired gases in the expired limb will not be washed out, and the expired air present in the expired limb will be breathed in, lead on to rebreathing. That is the most important point we have to remember. That is the answer they are expecting the examiners. So more lengthy and more than the tidal volume of the patient, there should be rebreathing will occur. And it will, if you reduce the diameter of the tubing, that will cause resistance also. These two things will happen. In other side, if there is expiratory limb is less than the tidal volume of the patient, what happens? Less than the tidal volume. Usually, have you heard about the term peak inspiratory flow? Peak inspiratory flow means during inspiration, and patient in spontaneous breathing or breathing, and the peak inspiratory flow rate should be at least 30 to 40 liters per second. That is the speed of air that is needed. With this flow rate, it is not possible to give by our anesthesia machine. Anesthesia machine will provide maximum of 12 liters per minute, that's all. So we cannot able to meet out the patient's demand of peak inspiratory flow during inspiration, and whatever the air, whatever the gases present in the expiratory limb will also be sucked out, and which is not adequate for the flow meter and the gases in the expiratory limb. So it will draw air from the atmosphere, lead on to air dilution. Can you able to follow me? So air dilution will occur if the expiratory limb is less than the tidal volume of the patient. That is the most important point, because we cannot able to meet out the peak inspiratory flow of 30 liter per minute, 30 to 40 liter per minute. That is the most important point. We have to remember it. And then regarding this fresh gas flow, how much you have to maintain it regarding this, what to say, this Jackson-Rees circuit, how much fresh gas flow we have to deliver to the patient to prevent air dilution or rebreathing. Most important thing is rebreathing. Why you have much bothered about this rebreathing? Rebreathing is nothing but inspiring the exhaled air which contains carbon dioxide. So we are giving this carbon dioxide more and more during each and every respiration, lead on to hypercarbia. That hypercarbia is a very dangerous in the pediatric population, and the patient will not recover at all at the end of your surgery. And that can be monitored. If you have a capnograph, you can able to perceive it, you can able to recognize it. And we had so many cases of laparoscopic surgery which will not be recovered in our operation theaters with using this Bain circuit. And the Bain circuit, the effective washout of carbon dioxide is very, very minimal. That is the most important drawback of this Bain circuit is concerned, which is not our scope of this lecture today. And at the end of the surgery, the patient was not put on capnograph, and I was called and entered into the theater for delayed recovery. And I will put the patient on capnography that shows that 70 millimeter of mercury of CpCO2. And then shout at the PG and throw away the Bain circuit, put the patient on closed circuit, and effectively ventilated, hyperventilated for 5 to 10 minutes. And gradually the PG can perceived the gradual fall of CO2 level, and that comes to normal, and then the patient was extubated. The problem is the hypercarbia is mounted for a long period of time. Suppose the patient is, the surgery duration time is more than 1 hour, continuous more than 1 hour, patient is having hypercarbia. That will produce so much of irreparable damages, and that will lead on to so many medical legal problems. So that is most important thing, whether the patient should not have rebreathing in any circuit you are using. That is the most important thing. That is why we are much bothered about this fresh gas flow, FGF. This fresh gas flow in the pediatric circuit is concerned, that should be 2.5 to 3 times the minute ventilation of the patient. You got to calculate the minute ventilation of the patient. Suppose the patient having 20 kg, what should be the minute ventilation of the patient? 20 into tidal volume into respiratory rate. 20 is the weight of the patient. Tidal volume 10 kg, 20 into 10, 20 into 10 is 200 into respiratory rate roughly about 20. If you say listen 20, it is not enough. Even though 20 is okay. For 20 into 20, 4,000 liters. For the 20 kg baby, the minute ventilation is 4,000 liters. It should be, that is the minute ventilation of the patient. It should be twice the minute ventilation. You can take it as granted. You should not take, for the pediatric is concerned, you can take a lesser value of the tidal volume. 7 ml per kg is enough. 7 ml per kg is enough for the patient. If the patient is on spontaneous ventilation, you should give at least definitely more than the 2.5 times the minute ventilation of the patient to prevent rebreathing. And if it is rebreathing of the patient, so minimal flow, whatever it may be, the minimal flow should be 3 to 4 liters. 4 liters. And next one is the double end bag. It is there here. Double-ended bag acts as a visual monitor. If you the Jackson, that is the most important advantage of this Jackson-Rees modification is concerned. The double-ended bag acts as a visual monitor during spontaneous ventilation. In addition, the bag can be used to assist or control ventilation. That is the most important advantage. We can monitor the patient. If the patient is in spontaneous, you can assess the spontaneous attempts, and you can assess the tidal volume taken by the patient also, because the bag will collapse and distend and collapse and distend. How much it is collapsing and how much it is distending, you can assume the adequate tidal volume can be delivered to the patient or not. Or patient may go in for a depth of ventilation. The tidal volume delivered by the patient during spontaneous ventilation is very, very minimal. You should be alert. You can lighten the anesthesia, or you have to assist ventilation, assist the ventilation to give adequate tidal volume to the patient. And during control ventilation, what bag can be used for an assisting device. Okay, so that is the most important, one of the important advantage of this double-ended bag attached to the end of the expiratory limb. And the next one is the bag can provide degree of continuous positive airway pressure during spontaneous ventilation. So the bag is giving CPAP, continuous positive pressure to the patient's airway. Thereby, that is an advantage for the pediatric population is concerned, because during expiration, the pediatric alveoli going for collapse. And if the CPAP applied by this bag throughout the phases of respiration, especially during at the end of expiration, and that will produce a positive pressure that will prevent airway collapse and recruitment of more alveoli. That is most advantageous in the pediatric population is concerned by using this Jackson-Rees modification. And this controlled ventilation is performed either by manual squeezing of the double-ended bag, or you can use this by intermittent occlusion of the reservoir tubing in the Mapleson E, or by removing the bag and connecting the reservoir tubing into a ventilator, such as specially designed anesthetic ventilator for pediatric population is concerned by Penlon nullified 2000. This is the ventilator circuit specially designed for pediatric controlled ventilation. But pediatric controlled ventilation, you can use this as an pressure control mode. That is the most important thing. If you use this volume control mode during this, that will lead on to barotrauma or VILI, that is called volutrauma, ventilator induced lung injury. That is the most common in pediatric population. So better we have to hand ventilate, the patient is more than adequate. So this is for the volume of the reservoir bag should be approximate to the patient tidal volume. And any other points I have missed, I don't know. And regarding this fresh gas flow, I have already told. And what happens if you are using this? Can I ask this? The T-piece is there. If it is wrongly fitted to the patient, what happens? You are this T-piece, the right angle, is connected to the fresh gas flow. If you connect this end as a patient end, if you connect this as a patient, I have entered the rounds during my IMC rounds. In those days, I usually take IMC rounds and PGs are there. And most of the staff nurses and I mean, fresh PGs are putting the right angle piece of a T-piece into the patient end. So what happens if you put like this? The examiner will ask you definitely. My examiner asked me during my MD examination. What happens? We put the patient on this, put the patient end, and one end to the source, oxygen source, fresh gas flow. And this is for the reservoir. This is for the patient, and this is for the fresh gas flow, and this is for the expiratory limb. What happens? Any ideas regarding this? You should not do it. If you do like this, what happens? It will produce an wrong resistance. Every time the patient is inspiring and expiring, any movement that will produce, and so much of pressure is produced, and the flow will become turbulent, and you can able to feel the resistance in the bag. It is enormously very high. And number two, this fresh gas flow coming through this, and there is an opening here, and the fresh gas flow is coming through this and coming out, and it is vented out. Here, this fresh gas flow with this opening here, that will produce an Venturi effect. The Venturi effect is, I have already told, I have taken already class regarding this principle physics of during my physics class. And this Venturi effect, that will suck the air from this atmosphere, and the pressure in the circuits will become very low, and the kinetic energies will become very enormous, and entrain more air, and entrain more air from the atmosphere from here to the patient, and that will lead on to so many problems. And first is the air dilution, and hypoanesthetic mixture is delivered, and the patient going for patient going for hypoanesthetic mixture, going for light anesthesia, and we cannot able to deepen the anesthesia even though more and more of anesthetic is given to the patient, number one. And if you increase the flow and the pressure drop here, and kinetic energy is so much, and entering more air into the lungs, that will produce volutrauma sometimes. So you should not wrongly fit this T-piece to the patient. So the right angle piece is always for fresh gas flow, and one for the patient end, and one for the expiratory port for the expiratory limb is concerned. Okay. And what is the idea behind this? I already told earlier in this slide. What to say, this CPAP effect. We are using this bag. I have already told you that CPAP effect is produced by adding this double-ended, double-blinded, unclosed. This reservoir bag is attached to the circuit. It will produce CPAP effect. That will be increasing the alveolar recruitment. The FRC in the pediatric circulation is very, very low, always. So the oxygen storage is very low. That is, FRC denotes that oxygen storage, and we can able to maintain the FRC very well by using this Jackson-Rees modification is concerned. And these are all the some of the points I have already covered all those things regarding this circuit is concerned, and the time is 8:49. And this mechanics of this circuit, the mechanics of the circuit during the first phase, during the first breathing is concerned. The fresh gas flow coming to, hello, anybody is talking? Hello? And I have not yet finished. Within 5 minutes, I will finish this mechanism, and I will open for discussion. And I expect every PG to ask questions regarding the circuit is concerned. I will ask, otherwise if you don't ask questions, I will ask you. And the fresh gas flow coming through this during the first phase of inspiration and coming here, and the patient is, it is delivered to the patient. Okay. And during expiration, whatever from here is coming there, and coming there, from here it is expelled out. And fresh gas from this here also coming here. Patient is not taking the fresh gas flow, and fresh gases here will push away or wash out all the expired air present in the expired limb will be washed away. So that is why here the double blinded bag that should be always open. You should not close it. Otherwise, there is no other go for the expired air to expelled out. It is the most important thing. Everybody should be remember it. The double-ended blinded reservoir bag should be always open during anesthesia. Okay, and it is during expiration. And next time, expiratory pause. Expiratory pause. There is no air movement from the patient. Expiratory pause, very few seconds. Roughly about 0.5 seconds, I think. And here the fresh gas flow will not get inside. So the fresh gas flow from here, that will be directly directed to the expiratory limb and wash out all the expired air present in the expiratory limb will be washed away. Here is the most important thing. I already told fresh gas flow should be 2.5 to 3 times the minute ventilation. Why? This amount of fresh gas flow, that is roughly about 6 liters for the pediatric is concerned. The 6 to 7 liters you are presented here for the older pediatric population, that will wash out all the air, expired air present in the expiratory limb. So the fresh gas flow more is not for the patient, that is for flushing out whatever the expired air present in the expiratory limb. And the expiratory limb volume is very higher. The time in the expiratory pause is very, very minimal, and whatever the gas present in the expiratory limb will not be flushed out completely. And next act of breathing, next inspiration, the fresh gas flow will come in. We are pressing here. We are assisting ventilation. Whatever the unexpelled expired air present here will be get inside the patient, lead on to rebreathing. So the most important thing you have to remember is the fresh gas flow should be more than 2 times the minute ventilation. That is for flushing out of the expired air in the expired limb. I am repeatedly telling, this is the question they will ask you in the examination, and I will ask you, I will call all the PGs into my room and I will ask you this regarding this circuit is concerned, and you should have to answer it. Please answer it. Please remember it. Now you can go and read this topic today, and then you can go for bed. I have elaborately explained regarding the circuit, whatever the drawbacks, how it is functioning, the mechanism and parts of the circuit, and how it behaves, and whom to give, and what are the advantages of the circuit. This is the most important thing. It's a very lightweight, and you can take this and take this circuit to anywhere else without any problem, and very simple construction. And the most important thing which was left here is it has no valves. Actually, it has no valves. But Jackson-Rees modification of Mapleson F that contain only one valve is there at the blind end to create a PEEP effect for this maintaining the efforts in this patient is concerned. Please, I will take water. And it is very expensive. It is disposable. It is made up of plastic. So because there is in other circuit there are so many valves. In closed circuit there are so many valves are there. It will produce high resistance. So the resistance offered by the circuit is very, very minimal. That is very needed for the pediatric population, because the pediatric airway is very, very narrow. So many bends, and the flow is always turbulent, mostly in the pediatric population, and we should not add fuel to this turbulent flow. And more the turbulent flow, more the pressure inside the pediatric airway, tracheobronchial tree, and more the resistance offered, that lead on to so many problems. Okay. So here we are using this dead space, and all the examiners will ask you, show me the dead space in the pediatric circuit. I have already told earlier, in the pediatric circuit, and where it is there, where is the dead space? Dead space is from here, and this portion from the dead space in the TPs, from the first gas flow to the patient end. From the first gas flow to the patient end, this cannot be flushed out. This cannot be flushed out. So the expired air composition is well maintained in that area, and that area expired air will be sucked inside during the next act of inspiration. So this is called the apparatus dead space. They will, any examiner, all the examiners are so much fond of asking you whether you can able to understand the circuit or not. They will show you where is the apparatus dead space in the pediatric circuit. It is from the first gas flow to the patient end. From the first gas flow to the patient end. It is very, very minimal. That is roughly about how much it will be, 5 to 6 ml or 7 ml. That's all. 5 to 6, that is the apparatus dead space. That is very, very, very minimal. And it can be used for controlled ventilation and also used for spontaneous. There is the most advantage. This is the only one circuit you can use for this controlled ventilation and spontaneous ventilation in the pediatric population. And scavenging is possible here, because scavenging we are not bothered about in our country, because very poor economic status. We doesn't bother about the air pollution and environmental pollution at all. That is a very sad state of affair. We are the only major persons. We are putting a hole in the ozone layer. So unless all the anesthetic gases will give a hole in the ozone layer, and we are doing this global greenhouse effect, and all the anesthetic gases will do this greenhouse effect. So in foreign countries, they are scavenging for preventing this theatre pollution and not the environmental pollution in the foreign countries also. So scavenging is possible. We cannot able to breathe the expired air of the patient inside the theatre. And our theatres are only AC operated, and we are not having the HEPA filters, and we are not having the laminar flow theatres, because every 12 seconds, all the air inside the theatre is totally expelled out by this laminar flow. So scavenging is present here. They are putting this APL valve, they are attaching in that bag, and this APL valve is connected to the scavenging system, and theatre pollution is prevented by using this Jackson-Rees modification is concerned. If they are using this TPs, it is not possible, this scavenging. If we use this Jackson-Rees modification, scavenging is possible. And what are the disadvantages? Disadvantages is always like that, and we are not using this any humidifiers. But if you use this HME filters, that will offer a resistance. That is a very tough thing. So lack of humidification, we are giving dry air at the room temperature. And here there is a wastage of gases here. You have to use the high press gas flow, 2.5 to 3 times the minute ventilation. And occlusion of the relief valve can increase the airway pressure and producing every chance for barotrauma. That is inevitable. You should be very careful regarding the pressure inside the circuit is concerned. Any pressure inside the circuit, any pressure, any problem in the valve, you should put away the this bag and you can ventilate. And this is for this. I think I have completed everything regarding this circuit for the more than 45 minutes. And any